The following program is a Town of Colony television production of the William K. Sanford Town Library.
Hi everyone, and welcome to Health and Wellness. My name is Paul Dreslow and I'll be your host. Today we're going to talk about spine and back related problems, topics such as treating and diagnosing herniated discs, osteoporosis, whiplash, and sciatica. To help us talk about some of these topics, we are very fortunate today to have Dr. Amar Parikh and Dr. John Whalen to talk about some of these topics with us today. So welcome, doctors. It's really great to have you here today.
Thank you.
Well, I thought we'd break it down into some specific topics and some general topics so we could just touch on some of the major reasons why someone might come to your office. Tell me something about herniated discs, either cervical or lumbar. What are some of the symptoms behind some of them? How do you usually treat them? Some of the modalities. What do you look for in diagnosing, basically? Dr. Parikh?
Well, first, the concept of a herniation in medical terms means something is no longer where it needs to be. Mm-hmm. And when we talk about the spine, we're talking about the shock absorbers or the discs. And when the disc is no longer where it needs to be, it generally slips backwards. And in the process of doing that, it can impinge upon nerve roots. And when you develop impingement upon the nerve root, you could develop all sorts of symptoms. You could develop shooting pains, you could develop numbness, you could develop tingling pains. Sometimes you can even develop weakness, and sometimes a constellation of all of those symptoms. If it's in the neck, it can happen in the upper extremities and the shoulder blades. It can even cause headache-type symptoms, and occasionally even symptoms in the lower extremities. Generally, when it's involved in the lower back or the lumbar spine, symptoms tend to be involved in the lower extremities or in the legs.
Right. So what about Dr. Whalen? Anything more to add on?
Well, that's a good summary. Basically, they can cause pain where they're located in the neck or back, and then pain or symptoms into the arms or legs, depending on which nerve they're pinching or impinging upon.
How does someone do that? Is it a particular activity, or is it just happen? You just wake up one morning and it just happens. You just feel the pain, or like how does it normally come about?
Well, there's different ways that it can happen. I mean, there certainly is a genetic predisposition for some folks, and that can be out of the control of you or I. And in those circumstances, you can wake up and develop certain symptoms like that. However, very frequently it could be a traumatic event, a motor vehicle accident, a fall, some sort of accident of some sort that could bring it about. And sometimes it could be a slow progression, sometimes because of work activities or sports. And sometimes it could be a combination of all of those events together.
How would you go about normally treating something like that, both from a medical standpoint, if there's any alternative type therapies that you might consider also? What would you usually look for? Or how would you normally treat that?
Well, usually we start with simple treatments for a herniated disc, because often these problems can be self-limited and improve with time, and non-surgical treatment. We would start with typically anti-inflammatory medications such as ibuprofen, Aleve, or prescription medications. Time, sometimes if you just wait, the symptoms can improve. Physical therapy or other treatments such as chiropractic treatment can help. If those things don't, as well as exercise, both home exercise as instructed by the physical therapist and just general exercise such as walking and being active can help. If those things don't help, then sometimes we need to progress to more invasive treatments.
Okay. Do you always start with something non-surgical, or is there a point in time where you see a particular patient comes in where there's just more extreme, you really have to do something surgically about it?
But from a surgical standpoint, usually that would be either a patient with completely unmanageable pain, where they can't wait and they can't even live with it in spite of pain medication. That's pretty rare. Usually an indication for doing surgery immediately is more a severe or progressive neurological problem where they have significant weakness or very rarely bowel or bladder disturbance from a herniated disc or spinal stenosis causing pinching of the nerves.
somewhat going along with that, sciatica is a leg type pain that you develop. What's the relationship between that and a lower back problem or a disc problem? How does that normally? What's the relationship between those two?
Well, interestingly, the discs have their own nerve supply. So you can, if you have damaged discs, I often tell my patients that a disc, it looks like a jelly donut, where there's jelly in the middle and there's a kind of a core on the outside. And if you were to squash a jelly donut, you'd get those little cracks on the outside. Well, a disc can develop small little tears on the outside, very similar to a donut. In the process of that, the disc itself can generate pain. Generally, that would present itself as just either neck or low back pain, can worsen with bending forward, rotational maneuvers. However, that disc itself can develop an inflammatory response, or itself can mechanically push upon a nerve root. When either the inflammation or the mechanical pushing upon a nerve root occurs, it can generate pain that could travel in the location of the nerve root, either down your arms or down your legs. And that's often what we refer to as a sciatica type pain.
Okay, and that's in the lower back, the sciatica?
Yeah, generally the sciatica type pain, what we refer to as the low back pain that occurs when it spreads down the lower extremities.
Okay, behind the thighs typically? Or?
Classically.
Yeah. Anything more, Doctor?
Sciatica is sort of a non-specific, more of a layman's term that describes, people usually use it to describe pain in the lower back, buttock, or even leg, but it's not as specific as the medical terms.
Okay, what about something like a degenerative type disc disease? So what's involved there? What does that look like from a diagnosis standpoint versus like a herniated type disc?
So when a disc is degenerated, that's more of a generic term. So what we're referring to is that shock absorber of your back has wear and tear, and that could be because of genetic predisposition, overuse, trauma, whatever it may be. And usually the best way to diagnose this is with an MRI to physically see it. Although clinically, the patient would often present with a lot of back pain that's focal to the back. Occasionally, that irritation over the disc can cause coexisting irritation on neighboring nerve roots and cause pain down the legs. However, what we often refer to as radicular type pain is the pain that shoots down the leg, which is separate but often related to the degenerative disc.
Basically, with degenerative disc disease, we all develop degenerative disc disease eventually. It's almost a fancy way of saying arthritis when it's more advanced. So over our lifetime, the discs do gradually degenerate. And some people that seems to cause a lot of pain, and some people don't have any pain at all with that.
Is this very heredity oriented, or is this something based on activity that you do, like where is it more tilted towards?
Probably both, but it really seems to run in families. Some people develop degenerative disc disease early. I've seen studies where they looked at identical twins with radically different occupations, such as one was an accountant and one was a ditch digger, say, or did heavy work all his life, and their MRIs were strikingly almost identical in patients who have lived very different lives in terms of how heavily they've used their back.
It's a nature versus nurture sort of discussion that we're talking about here. So certainly there is a predisposition, but then there are certain activities that you can do that can bring it about or make you more predisposed or inclined to having pain. And obviously a person who has a predisposition to that and then is involved in an acute traumatic event such as a motor vehicle accident or a major fall would be more susceptible to advanced symptoms as opposed to someone who's not.
What ages do you typically see disc type problems with people? Does it matter at all, or is it more older, or does it take like a lifetime of work to really accumulate, or does the predisposition, can it strike when you're 20s or whenever? What do you usually typically see?
It really depends which problem you're talking about. A herniated disc is more common in younger people. The degenerative conditions are obviously more common in older people. Herniated disc can happen at any age. I've seen them in people in their 80s even. But they tend to be a little bit more involving herniated discs in the younger people.
Okay. When someone comes in with a disc problem, do you typically, what's usually like the percent, or like how often is surgery actually required in something like this? Or you're normally able to treat people with non-surgical type methods?
Most frequently, you can treat patients with non-surgical methods, and that's generally the way that we prefer to manage these sorts of pain issues. There are exceptions to that rule, and as Dr. Whalen had alluded to, if there are some clear neurological signs or symptoms that would warrant immediate surgery, that would be a separate story. However, for most patients that come through the door, the natural course is that these things do tend to resolve with time. In order to help you bridge you from point A to point B, there are some medications that we can use, physical therapy sorts of interventions, and even some interventions that we can perform to the spine to help a patient progress from point A to point B.
Okay. And chiropractors and physical therapists are the usual non-surgical specialists that you might refer patients to, or is there something else that you might use also?
Yes, that's very common, and as I said before, anti-inflammatory medications, time, exercise. Dr. Parikh does some invasive pain management techniques with injections that are certainly much less than surgery that can be very helpful.
All right, enough on disc. Let's move on to osteoporosis. Tell me something about what that is, who's at risk for it, just generally speaking.
So when we talk about osteoporosis, we're talking about decrease in overall bone strength. And classically, when we think about decrease in bone strength, we think about those who are advanced in age. So that's going to be your your most common patient is someone who's advanced in age. For women, generally above 65. For men, 70 years and above. However, osteoporosis can be caused about by a series of other things, including medical conditions, women who've had their ovaries taken out or uterus taken out, men who've had some of their gonads taken out as well. Medications can do it.
Right.
Chronic steroidal use for some patients, whether or not it was for a medical condition or had been receiving it for other sorts of issues, can do it. There are certain medications that are prescribed. Antacids and heartburn medications can do it. So there's a lot of things that can bring it about, as well as, of course, smoking and alcohol consumption, another big risk factors.
How does someone know that they have it? Do they have an accident and it's discovered, or is it something more obvious that someone in their 70s or 80s might see?
Well, the easiest way to find it out is with a bone density test. However, a lot of people discover they have osteoporosis by a fragility fracture, we call it, where the bone is weak and they have a minor fall and they break, say, their wrist or even a hip. And then that's sort of the hard way to find out.
Right. How does it typically progress? Is it just go through a progression, or does it actually stop at a certain point? How does it? What's its life cycle? Can you?
Well, to be perfectly honest, in the medical literature, we don't know exactly how osteoporosis will progress, and for that reason, there's no set standard screening policies that are used for osteoporosis. Generally, if there is considered to be high risk for women generally above the age of 65 and men above the age of 70, as Dr. Whalen alluded to, a DEXA scan would be suggested just for a baseline study. However, if a person develops a fracture, or develops some sort of a peculiar finding that would warrant a physician to suspect osteoporosis, that certainly would bring it about either younger or a later age, depending on how it goes. But there's no way to risk stratify on the literature aside from just generic principles.
How often should someone who is in their 60s, 70s, or 80s come in for a bone density test? Like, what do you recommend that people typically do, even if they've had no sign at all?
Generally, what's recommended is to at least have a baseline study done. At that point, most of it is going to be about prevention. So for both women and for men, calcium and vitamin D supplementation are paramount. That's particularly an issue here living in the Northeast, where sunlight is at a premium, particularly during the long winter months. So as long as they're taking their supplementation and using the preventative measures, that's usually up to the discretion of the patient and the physician based on how their actual day-to-day pain goes about if they were to develop new pain symptoms.
Is there any particular exercises? You mentioned vitamin supplements. Is there anything physically, like any particular physical type exercise you might recommend as lifting weights or cardio? Does it make any difference or not? Or
well, exercise that has your body move against gravity, such as walking, probably a Stairmaster, any of those sort of things where you're moving your own weight, that really helps to increase the bone density, or at least avoid losing bone density.
Okay. And that's someone should do that the way that they typically would exercise 3 or 4 times a week, 30 or 40 minutes, whatever.
Right, and to just stay active in general.
Right.
And for each patient, that degree of exercise may vary. The key thing is to avoid sedentary activity. You don't want to be sitting for long periods of the time because you hurt. And that's our largest challenge is patients who do have coexisting pain issues are so fearful of moving that they can develop worsening underlying bone disease because of the lack of mobility. So the key thing is if you can't move or you can't do basic activities, to work with a therapist or work with someone at home that can at least keep your activity level at a baseline.
Is that typically covered by insurance, that type of that type of therapy? If someone can't actually move in a situation like that, would insurance typically pick something like that up, or?
Well, the challenge in the United States is that there's so much discrepancy between one insurance and the other insurance. So it's never there's no correct answer to that, and for each individual patient that varies. So I'm always cautious about telling all their patients to fully know what their insurance plans do cover. However, for those where there is a challenge in terms of coverage, at least a few sessions of therapy to teach them some basic exercise modalities can then be used at home in a home exercise program that they can teach it themselves, as well as having family members or friends for support.
All right. Let's move on to whiplash. Tell me something about that. What it is, what causes it, why do people come into your office with that type of a condition typically?
Whiplash, most commonly we see someone who's had a motor vehicle accident, most commonly a rear-end motor vehicle accident. They're diagnosed with whiplash, which is really a non-specific, sort of a layman's term for an injury to the neck typically. And we would call that a cervical sprain would be the medical term for it. They tend to be self-limited, but if they have ongoing symptoms, then we would work the patient up in terms of getting x-rays, MRI, to see if there's an underlying cause of it, or if it's really just a sprain that hasn't gotten better.
If it is, just looking at it as a sprain, I take it there's non-medical type exercises or modalities that you might use in that case?
Right, very similar to the conservative treatments we've talked about before, therapy and anti-inflammatories, occasionally pain medication, exercise. If it's not self-limiting though, then the next step would be to look into it further with specific tests.
Is there any research being done on whiplash right now? Anything further?
I don't know of anything specific to tell you, but that's a study of research.
Yeah, the concept of whiplash is that there's varying degrees of severity of whiplash. So depending on the severity of your specific injury, it's going to vary based on the treatment modalities that are going to be researched and going to be utilized. There's a Quebec task force that is designated a grade 0 to grade 4 severity. Grade 0 being those that have really no pain symptoms at all, just a history of injury with the classic acceleration, deceleration, motion of their head, versus a grade 4 where they develop fractures in their neck, as well as some neurological sequelae that can come along with that. For those patients, there may be some surgical interventions that are warranted, but for most patients that fall within that, it's mostly conservative measures that have been previously discussed. So, based on that, there's so much variance between patient to patient that's where most of our effort goes, is trying to designate their overall location of pain and figuring out how to treat that.
Okay, let's move on to spinal stenosis. It's maybe something people haven't heard much of. What is that? And again, what causes it? Who might get something like that typically?
So stenosis, again, in the medical terms, anytime we use the word stenosis is a medical word for narrow. And when we say spinal stenosis, we're referring to narrowing of the spine. And there's a lot of things that can cause that. Spinal stenosis can be caused by degenerative disc disease. It can be caused by arthritis, also by overgrowth of your natural connective tissue within your spine. So the key thing to remember is that your spine is intrinsically narrow. You want it to be narrow to protect your spinal cord as well as all of its neighboring nerve roots. However, the double-edged sword to that is that there's a low threshold that with wear and tear to your spine that you can continue to narrow those holes, and can cause pain. Now, the characteristic presentation would be pain either in the back or going down to legs or into the neck or going into the arms. That tends to worsen with activity as well as sedentary activity. So sitting for long periods of time, standing for long periods of time, walking, generally going down a set of stairs can be equal or more painful than even going up a set of stairs. Sitting or flexion of the back tends to improve pain symptoms. Although those are the general rubric, there can be some variation from patient to patient.
Okay, how does that typically happen, or why does that typically happen and the spine actually narrow? Is it just from activity, or is it just from, again, more heredity, or what's typically?
Well, as Dr. Parikh alluded to, there's many conditions that can cause spinal stenosis. That is a term that means narrowing of the spinal canal, the hole where the nerves go. Right. And that can happen from a herniated disc can cause narrowing there. The degeneration and arthritis can cause that. We also see a condition called spondylolisthesis, which is a forward slippage of the vertebrae where one vertebrae slips forward on the other one. And if you can imagine a tube where the spinal cord and the nerves go, as it slips, it tends to pinch the nerves as well. It can occur from tumors or cancers or infection, many other causes of it.
So it's really in a specific area. It's not the whole column. It's just, or most of the column. It's just in a specific.
Usually, yes.
Yeah. Now you can have patients with advanced spinal stenosis with multiple levels of findings that are similar to varying degrees. Some of those levels of stenosis may not be symptomatic at all. Mm-hmm. However, there may be other levels of stenosis that would be symptomatic, and that's what brings them into the office.
Does this usually occur in younger people, older people, or does it makes no difference at all? What point in life do people typically develop something like this?
It's more common in older people on a degenerative basis, basically from arthritis and overgrowth of some of the normal structures in the spine.
Okay. All right. What, generally speaking, in your field, in any of these areas or anything that we didn't talk about, what have you seen over the course of your careers that's been really great in terms of advancements and treating people with spinal type problems? What's been really recently or more back in the past, whatever, what's happened over the past 10, 20 years that's been really helpful in your field?
Well, I feel in our practice one advance that has really helped is bringing together different specialties. As a spine surgeon, I work with our pain management specialists, and so you get a more comprehensive treatment. You know, it used to be if you saw a surgeon, you got surgery. If you saw a pain management doctor, you got injections. Mm-hmm. If you saw a physiatrist, you got physical therapy. I mean, it's really become more of a comprehensive treatment where patients are brought through the stages of treatment from the least invasive to the most invasive if necessary. If they get better along the way, then they would avoid having, say, a surgery or an injection.
Why does that happen? Is that just because people are co-located, or how is that happening? Is there any particular reason why people seem to be communicating or sharing information better, or is there any reason why that is?
Well, I think part of the reason that's happening is because our understanding of the spine has increased greatly as the decades have passed. There was a time where people developed back pain. The thought process was that you take away their pain. Oftentimes we'd use painkillers at high doses. As we've started to learn, painkillers actually pose equal to more risk than they do benefits. And although there is a place for the painkillers, there's also an equal and probably better place for using multiple modes of therapy in order to control pain. There's a concept in pain management referred to as multimodal pain management. Essentially what that means is we're treating pain with multiple different venues. That way allows you to use smaller amounts of a lot of different things. I tell patients it's kind of like going to war and attacking from land, air, and sea. Mm-hmm. Not putting all your troops on one destination and trying to fight a battle that way. So the more angles that we attack pain from, the better the results generally are, and that includes primary care practitioners, specialists, surgeons, acupuncturists, massage therapists, chiropractors, physical therapists, the full gamut of providers who can actually oversee this care of the patient.
It actually brings up another question. How do you use acupuncture is frequently used in spinal problems? Is it something that you refer people to, or they just do it on their own? Like, how does that? How do you work with either non-chiropractors or more alternative type therapists other than you typically use?
I've seen it help. I'm not trained in acupuncture, and I can't tell you too much about how or why it works, but I've had patients get better with it. Usually that's something that we would try in some patients when other modalities hadn't worked.
Okay.
The key thing to remember is that there are certain surgical emergencies that need to be done and treated surgically. For those that are not surgical procedures, most of the things we do are elective, and it warrants a discussion between the physician and their patient to come up with a plan. Now, based on certain cultural norms, acupuncture may be considered to be the first line treatment. And
Right.
for other folks who've already tried and failed other modalities, acupuncture may be an option for them. However, for others, the thought of going to a chiropractor would be blasphemy. And for others, the thought of going to a therapist who have failed to respond to therapy for their knees would certainly not want to go to a therapist for their back. So the key thing is to have the communication with the patient, make sure that we are all on the same page as to what our goals are, and explain to what expectations can be. And just because they go to acupuncture doesn't mean that they can't also do massage, or they can't also take a medicine that may help them out. So it's really mixing and matching and coming up with a modality for that individual patient that works best.
Okay. What do you see getting better in the next 10 or so years? Is there anything that's coming up that people might want to look for, either who have a spine problem or someone might be concerned about it? Is there anything coming up in the next 10 or 15 years that might help more?
Well, we're always working on these sort of problems as research in many areas. One thing we haven't touched on here is the role of smoking in spinal problems, but there's a big cause and effect relationship between smoking and most of the problems that we've talked about. Smoking increases the chance of getting degenerative disc disease, symptomatic spinal stenosis, and many of these other conditions are related to that, as well as success rates after surgery. So that can be a big issue, and that's one thing that people can at least have the hope of controlling in their life.
Yeah, I think the key thing, as Dr. Whalen has alluded to, is awareness amongst patients. It's understanding about what it is that's going on with them, understanding of preventative measures that can be used. Because truthfully, for all the treatments that are offered, not one treatment may work for everybody. You may have a treatment for one that works well and for another one that doesn't work well. And that includes a position that works well for one person may not work well as a surgery for one, or an intervention to a spine that works for one may not work for the other. So a lot of it is really based on working with that individual patient to come up with a program. Now, that being said, there's minimally invasive surgeries that are being offered. There's advanced spinal cord stimulation therapy. There's platelet-rich plasma that's being considered to be injected into certain areas of the spine, stem cell research that's undergoing. So there's a whole lot of different modalities that are being thought about as we work forwards. But again, no one modality is necessarily going to work for that individual patient.
Is there anything else you think that we haven't touched on that you might want to say to anyone, that anything in particular or specific, or we wrap up?
Well, just to go along with the concept of smoking cessation, a lot of what we see, especially in the United States, is related to nutrition and obesity. Dietary modification is a critical component of managing spine-related pain. Weight loss and core body strengthening and conditioning is critical to establishing your spine as being healthy. For often patients who have deteriorated spine, the best form of treatment is strengthening the things that you have control over, and that's the muscle groups, and that's the weight that surrounds it. And that's a great way to not necessarily eradicate pain, but certainly mitigate pain and make pain tolerable for a lot of people.
And that would apply to any of the things we just talked about?
Absolutely.
Right. Okay. All right. Well, I think that about wraps up what we wanted to present on this topic. I want to thank Dr. Parikh and Dr. Whalen for coming in today and taking time out of their very busy schedules. And I want to thank you for watching. I hope you tune in next time for the next edition of Health and Wellness. And take care and have a really great day.